Good morning. My name is Erik Bényei. I'm from the Department of Internal Medicine and Oncology, Semmelweis University, Hungary. And in this upcoming case presentation, I would like to summarize the 15-year-long medical history of our patient with pheochromocytomatosis. And in order to illustrate this complicated history in the best possible way, I decided to use a timeline. So, in 2011, a 33-year-old male patient presented with episodic palpitations and hypertensive surges. The performed imaging procedures and laboratory tests confirmed a 6 centimeter large adrenaline-producing pheochromocytoma in the left adrenal gland. As first-line treatment, a left-sided adrenalectomy was performed, and for the following 5 years, the patient remained asymptomatic with regular follow-up imaging procedures showing no sign of recurrence. This remained the case until 2016, when the patient's symptoms recurred. MIBG scintigraphy revealed a lesion at the left renal hilum, consistent with a tumor recurrence, which was further supported by repeatedly elevated biochemical markers. The therapeutic decision was to proceed with a reoperation that took place in 2017. During the operation, however, the surgeon encountered an unexpected finding. Along with a massive perisplenic infiltration, several tumoral deposits measuring 2 to 3 millimeters in size were observed throughout the left hypochondrium. Due to the irresecability of these lesions, the only option was to perform a debulking surgery. And consistent with these intraoperative findings, on the postoperative MIBG scan, multiple peritoneal lesions with pathological radiopharmaceutical uptake can be observed. So, after the discovery of this unusual peritoneal dissemination, the question arose, do these observed abnormalities represent metastasis, or could they be something else? And in order to properly answer this question, it was necessary to go back to 2011, and after obtaining the original surgical report, this sentence revealed the true nature of the disease, and I quote, "The large tumor could not be placed in the endobag and required deliberate fragmentation and manual extraction." So, based on this information, the diagnosis of pheochromocytomatosis was made in 2017. But what is pheochromocytomatosis exactly? It's an infrequent iatrogenic complication of pheochromocytoma surgery, defined as the implantation of pheochromocytoma cells in the operatively open space. As pheochromocytomas are really fragile tumors, capsule rupture can easily lead to the peritoneal dissemination of neoplastic cells. For the following 6 years, a watch-and-wait strategy was applied, and the patient was on symptomatic treatment using alpha and beta blockers, and he only experienced some easy-to-tolerate symptoms. Regular MIBG scans showed a slight increase in the size of the known lesions, but there was no clear evidence of tumor progression. This favorable condition, however, could only be sustained until 2023, when clear tumor progression finally occurred. It was defined by more frequent and intense symptoms, new lesions appearing on the MIBG scan, and deteriorating biochemical parameters. On this graph, we illustrated all available urine metanephrine and normetanephrine levels, and as you can see, following a decrease after the debulking surgery performed in 2017, the patient's biochemical parameters remained stable for years. But around 23, along with worsening symptoms and radiological progression, these laboratory results also show some really concerning changes. For treatment, the patient received 2 cycles of MIBG therapy, but unfortunately, further deteriorating biochemical parameters were measured both between and after the treatments, and radiological progression was also noted. Given that there is no guideline for pheochromocytomatosis and barely any literature available on the condition, we discussed how we could mirror the therapeutic options used in advanced metastatic pheochromocytomas. With the debulking surgery performed in 2017, tumor progression occurred after 6 years of watch and wait. We performed a somatostatin receptor scintigraphy for the patient, which was negative, so somatostatin-based treatments were not an option. His tumor has already progressed after 2 cycles of MIBG therapy, so the only option we are left with are tyrosine kinase inhibitors, and so the patient was started in sunitinib in 25. At the same time, it's really important to acknowledge the concerning possibility of exhausting all available treatment options. I purposely did not mention an earlier result. In 2016, we conducted a genetic analysis, and no germline mutations associated with pheochromocytomas were identified that would have made the patient a suitable candidate for targeted therapy. But this raises a very important question, because what if a targetable somatic mutation could be identified from the tumor tissue? And this is a very difficult topic. One of the fundamental rules in endocrinology is that due to the high risk associated with catecholamine release, you should never perform a biopsy on an adrenal tumor or a pheochromocytoma. But after a thorough multidisciplinary cost-benefit assessment, it was concluded that this is one of those exceptional cases where the potential benefit may outweigh the risk, and the procedure was justified in order to identify a targetable somatic mutation. This biopsy is actually scheduled to take place in the upcoming weeks, and right now we are preparing for the procedure and hope for the best. And besides these conclusions that I have already mentioned, I want to highlight one of the probably the most important key aspects of this case, which is that if the clinical situation demands it, reviewing and reevaluating old medical records can significantly impact the course of patient management, and it can lead to improvements in both quality of life and survival. Thank you.
Thank you very much. Again, fantastic presentation. Fortunately, this complication is very rare. We have a huge paraganglioma practice back home. My question to you is, was initially a 24-hour urine methoxytyramine level ordered, number one, and why would I ask that regarding the methoxytyramine? Second thing is that what are other risk factors here suggesting that this may be a malignant tumor? Because with pheochromocytoma, you can't predict malignancy. Even on tissue diagnosis, is something that you just got to follow them up for, unlike many other solid tumors. And my third question is that when you did the somatostatin receptor scintigraphy, was octreotide used or dotatate was used? Okay, thank you. So the first question was whether we measured the urine metanephrine and normetanephrine levels, and we measured them in 2011 when the patient or the treating institution at the time measured them when the first diagnosis was made, and it was elevated. The adrenaline levels were 35 times bigger than the upper limit of the normal range, approximately. The second question was what is I think that was not measured because we decided that this tumor is adrenaline producing, and therefore we try to follow metanephrine and normetanephrine levels. Yeah, the reason why I'm asking about methoxytyramine is because methoxytyramine, in addition to metanephrines and normetanephrines, has a higher risk of potential malignancy risk. It's dopamine metabolite. So it might have given you a clue to follow them even closer. Yes, thank you. And the second question was, can you remind me, sorry, Any other risk factors for... Yeah, the risk factors. So we feel like that the reason why this case is so interesting because this tumor has disseminated mechanically, but it started to behave like a malignant tumor later over time. So for 6 years, this patient was stable with conservative therapy without any active oncological treatment. But after 6 years, his symptoms has become more intense and more frequent. New lesions were appearing on the MIBG scan, and you could see that the urine metanephrine and normetanephrine levels were rapidly rising. So these three factors were, based on these three factors, we said that this tumor has become malignant over time, and not at the moment when it disseminated. I hope.
Professor Preptani, do we think about something like that before pheochromocytoma operations? I mean, you supervise a lot of them.
So there are some risk factors that you got to follow them closer. Genetic mutations, for example, especially the SDHB mutation, which carries a higher risk of malignancy, higher methoxytyramine levels, and the size. The bigger the size, especially if it's over 6 to 8 centimeters, the risk of malignancy goes higher. And inadequate resection and anything concerning on the operative field, these are some of the risk factors that make you follow them closer. And of course, if there's extra-adrenal disease, which makes you concerned also, whether it's anywhere along the sympathetic chain, cardiac paragangliomas, head and neck paragangliomas, these are much more concerning than intraadrenal pheochromocytomas. And my last question was dotatate used or octreotide used?
Octreotide.
It's not very sensitive.
Yes. Yes, that is the...
Microphone, please.
Gallium-68 PET dotatate is much more sensitive than octreotide, indium octreotide.
Yes, and we want to use, but unfortunately it is not available in our country, so we only have octreotide.
Well, thank you. We have to stop now. Thank you.